Good day to you. We are going to talk about one of my favorite subjects. This disease is so common, so well represented among the other disease contenders, and extremely simple to manage, but oh so complicated at the same time. Okay, no freaking out just because I said that. It is complicated, but it doesn't mean it's hard or impossible to understand. That's why I feel like it's sort of simple. We just need to keep a person's blood sugar within normal ranges if a person has diabetes. If we can do that, then the body won't fall apart organ by organ. It will all stay together. In today's lesson, I hope you learn what causes diabetes, the signs and symptoms of blood sugar changes, the complications of diabetes, and most importantly, how our nurses going to best manage patients who have diabetes. So let's get to it. Here you are. You're a nurse reviewing your MAR, and the MAR states that the diabetic patient is scheduled for insulin at 11:30. This is what a nurse is typically looking at. And you, the nurse, your eyes are looking at this as well. Well, what the heck is this? It's a sliding scale, which I like to call it the if this then that scale. If I say your patient has a blood sugar of 249, how many units are you going to give? Okay, come on. How many units are you going to give? Oh, you have a question for me, do you? Well, pretend I'm the doctor who just gave you this order, give insulin for the sliding scale. And you know that you're going to have to look at this. I would like your next question to be, well, which sliding scale do you want, doctor? And they say, oh yes, the low sliding scale, the low one. That's what I want. And yes, this is my real voice. Anyway, all right, so now for the blood sugar of 249, you know you need a low sliding scale to apply to that sugar. How much insulin are you going to give this patient? Right, 6 units. Great job. So now you know 6 units is what you need to give the patient, and you go into the supply room to grab your syringes, and wow, there are some choices. Here are the 2 contenders, and I'll give you a hint of which one is the correct one. It is the orange cap one. The orange cap. Well, I'll tell you this is a medical error waiting to happen because a lot of people associate the correct insulin syringe as the orange hubbed one, not the orange cap. So please be very conscious when you go into the medical supply room and grab the one that is the orange cap. And also, if you look really closely, that says units there as we measure insulin in units. And here you can't tell. That actually on one side will say ml. Here we go. Sorry. Okay. So we know to grab the orange cap one. Let's pretend in my little story you sort of forgot to grab the orange cap. And when you pull the 2 together, you will see a little bit of a difference in numbers. But gosh, if you're not paying attention and you just grab the other one and you have in your mind that you need to give 6 units, there is a pretty good chance you will just measure out to the 6, which is a drastic difference from this 6 right up there. And before you know it, your 6 units that you're supposed to give actually turned into a quick 60 units that you gave your patient. So I cannot emphasize this enough. Grab the insulin syringe that has the orange cap, not the orange hub. Okay, I think you get it. All right, now, which one of these do you want to grab? Pause if you need to. Can any of these allow you to safely administer 6 units of insulin? Okay, yes, actually. These are all different syringes to measure out 6 units, but if you had all 3 options available, you should probably grab for the one on the left, the 30 unit one. Good. So you have your 30 unit syringe and you're on your way to give your medication, and you pull up insulin in the med dispenser Pyxis machine and you see this. Oh my gosh. What? I said insulin. I don't remember anything about Humulin N or R or Novolin or Novolog. Eek! So looks like you got to call that doc back and say, hi, it's me again, your favorite nurse. Right. Okay, so about that insulin you wanted your patient to have? Yep. So I'm excited to tell you, students, that by the end of this lecture, you will be well versed in insulinese. Right, that's a language I totally made up. Stay tuned to find out which of these insulins will be given for a sliding scale blood sugar. But if you want a hint, it will probably be this one or this one. Okay. Don't tell anybody I told you. Well, what do we know about diabetes? What do you know about diabetes? Does your grandma have it? I mean, do you have it? Do nobody you know have it? I want you to write anything that comes to mind. Okay? I'm going to put 30 seconds on my clock. And just go ahead and write down anything that comes to mind. Ready? Go. Seconds. Okay, whew, that was a long time for me. All right, so look at your answers. Most students write things like sugar, insulin, obesity, genetic, insulin dependent, non-insulin dependent, type 1, type 2, shots, insulin pumps, glucometers, carb-controlled diet, hypoglycemia, hyperglycemia, and maybe things like that. I'll give you 1 point for those answers because they're kind of basic. When we talk about diabetes, those word associations come to mind. But I'll give you 5 points if you put something like this: polycystic ovarian syndrome, diabetic ketoacidosis, blindness, kidney disease, stroke, peripheral vascular disease, CT contrast contraindications, shaky, cool, clammy, confused, maybe even seizure. Did you put down polyphagia or polyuria? Maybe polydipsia? How about prolonged wound healing or amputations? You guys get 5 points for that one. Great job, everybody. I know those are not exam points. Those are just attaboys. This picture may be very familiar to you, maybe from pathophysiology or anatomy and physiology, but insulin is the key for sugar to get into a cell. Losing your keys means processes are interrupted. How annoying is that? Well, the body, it thinks it's actually pretty annoying, really. Sugar, specifically glucose, will just sit in the bloodstream with nowhere to go and nothing to do. And that's not good. We know this specifically as hyperglycemia, too much sugar in the blood. And this changes a lot of things because our body, specifically the cells, are going to begin to starve. The starvation of glucose and nutrients at the cellular level begins to signal throughout the body that it needs to do something to get those cells some energy. Well, the body is magnificent and that it can, steal some from the liver, but if it happens over a long period of time, that sugar just sits in the veins, not go anywhere, it's gonna begin to break down fat. Well, this is excellent. If there was a shortage of sugar, maybe we were on a desert island and we had nothing to eat, we could live off our fat for a little bit. However, in our diabetic patients, we cannot continuously break down our own fat and continue to ingest food that breaks down to sugar. We are going to have a major sugar overload inside our bloodstreams. major. We're also going to have another problem. So when the fat breaks down, it breaks down into these fatty acids. They're released into the bloodstream. And these fatty acids are known as ketones. And as the name implies, they have an acidic element to that. And then it's going to make the blood super hard to handle for the body because it's very acidic. These ketones are going to add up. We're going to tip our pH scales. The person's going to now develop what we call ketoacidosis, and the body is going to try to compensate. In fact, one way to get rid of the acid is to use the respiratory system. Do you remember those respirations, the specific ones? Exactly, Kussmaul's respirations. They're going to try to breathe off some of that CO2. And if you get close enough to that patient while they are trying to, compensate for the ketoacidosis, you're going to smell a very fruity, sweet, acetone-like breath. Now, in my opinion, it smells like a fermented apple. Yeah, like a really fermented apple. Not good. Now, go bag one up in a Ziploc, stick it in the sun for a week, and then open it and sniff. I actually bet you're going to try this because I know you want to know what fruity, sweet acetone smells like. I mean, I would do it. I don't know. Okay, so now the glucose molecules are adding up in the bloodstream, and this is going to generate some pressure in the renal tubules to begin to spill the extra sugar, and it's going to get peed out. Well, when the sugar gets peed out, so does the fluid. The body cannot actually expel the sugar without the excessive urine loss too. So our patients are actually going to begin to have excessive urine output as the sugar gets higher and higher. We're going to call this polyuria. A patient's going to have polyuria, excessive urine output. And with polyuria, dehydration sets in. And your person is going to get excessively thirsty. They're going to call this polydipsia, excessive thirst. You know, my first semester of teaching, this one student of mine always sat in the front, and she came to class with 1 gallon of water, which she consumed in our 3-hour class. I mean, to me, I didn't think much of it because she was fit, she was athletic, thin, very health conscious. I just kind of wrote it off because, water is a health choice for a lot of people. Excessive water, I should say. Well, then she began to bring 2 gallons of water to class and consume both of them during a 3-hour period. When I asked her during break how many gallons she actually drinks in a day, she said, 5 on a bad day, but generally 7 gallons. I was like, are you comfortable with that? I mean, for most people, that's actually not normal. Do you still feel thirsty? And she said, yes, actually. So I encouraged her to go and get checked out, and turns out she had diabetes type 1, which we'll learn shortly. Anyways, back to the high blood sugar. So polydipsia, excessive thirst, because you are having polyuria. All right, and remember, our body is starving. So what do starving people want? What do starving people crave? I don't know, food? Yep. That almost looks like a picture of me secretly eating carbs. Okay. Anticipate your person to have polyphagia. That's polyphagia with a G. I don't know why I can't say it correctly. Polyphagia. Sounds like a J, but it's a G. It is just a matter of days, maybe weeks. It could, be 2 or 3 weeks, or even 4, before severe dehydration sets in, and now we have hemoconcentration of the blood, hyperviscosity of the blood, and hypovolemia. Yay for low blood pressure and possibly kidney failure. So this is what happens when we have little to no insulin in our bloodstream. It tends to not go so well. All right, let me go ahead and describe to you a pre-diabetic syndrome called Syndrome X. It is a cluster of conditions that increase the risk of heart disease, stroke, and diabetes. And once again, we call this X syndrome, but I like to say they have the X factor. There you go. Okay, the first symptom for syndrome X is abdominal obesity. This is when a patient has a waist circumference of 40 inches or more for males and 35 inches or more for females. Let me repeat that. A waist circumference of 40 inches or more for men and 35 inches or more for females. I know, they get 5 more inches. Ugh. The next thing is hyperglycemia. This is when their fasting blood sugar is greater than 100 and or they are on treatment for elevated blood sugar levels. I know, can we just go ahead and call them diabetic? But yep, that's hyperglycemia. Okay, next. This is when a patient has hypertension. Their systolic blood pressure is 130 or more, and their diastolic blood pressure is 85 or more, and they are possibly on drugs for hypertension. I know. Here's another symptom for metabolic syndrome, or syndrome X. Hyperlipidemia. Here's some numbers for you. Hyperlipidemia. This is when their triglyceride level is greater than 150. Right? So their triglyceride level is greater than 150, or if they're on medications to treat their high lipids. And if their HDLs are less than 40, HDL stands for high density lipoprotein. If that's less than 40, that is not good, and that's for men. And women, we have a little bit more if it's less than 50. Let me just repeat those numbers. Triglycerides greater than 150, or if they're on drugs for high cholesterol, or if their HDLs are less than 40 for men and less than 50 for females. Then our patient has got all of the makings for developing diabetes. And this is where we need to recognize that a patient is pre-diabetic, and we need to intervene as best as possible to reduce their weight, get their sugars a little bit less than 100, which I do know in this picture it says fasting blood sugar greater than 110, but you guys, I need you to remember 100. Let's get their blood pressure down and their cholesterol down. I think the HDL numbers are a little bit off too on my picture. Well, that's what you get from finding from the internet. So, who should we test for diabetes? There is a lovely table of all of the different populations of people and characteristics that patients have that would indicate to us practitioners that we need to test them. Just to mention a few, maybe they have a first-degree relative who is diabetic, like your mom is diabetic. Let's check you. Maybe your BMI is greater than 25. You are overweight or obese or morbidly obese. If you are of the ethnicity African American, Hispanic, or American Indian, or even Pacific Islander, diabetes tends to run higher in those ethnic groups. Maybe you're pregnant and you had delivered your baby, but the baby was very heavy, meaning it was greater than 9 pounds. You might develop diabetes and we need to check you. If you're hypertensive, let's assess for diabetes. If your HDL is low, or maybe your triglycerides are high, I feel like I just covered this. If you have polycystic ovarian syndrome, that might be an indicator that you are prone to develop diabetes, so we want early treatment of that. There is a test called hemoglobin A1C, which I'll go over in just a little bit, but if it is elevated, we need to test for diabetes. Maybe you have a history of vascular disease, such as coronary artery disease or PVD, PAD, one of those, any of those really. How about our Vietnam veterans, or really veterans from a different war, I think might have been exposed to Agent Orange. That has been shown to exposure to Agent Orange, those people do develop diabetes a little bit later. Be very suspicious if you hear that in their history, not your history, hopefully not your history. All right, lab test. Labs. One of the easiest tests we can do is a fasting plasma sugar level, or FPG. Your patient needs to be NPO for 8 hours, and I think they can only drink water prior to that time, and you are going to check their blood sugar and see what their fasting plasma level is. I have the normals on the next page, so I won't rattle them off to you here, but that is what a fasting plasma glucose level is. Oftentimes, whenever you have lab work done at your doctor's office, they say, now make sure you know these are fasting labs, because one of the things they want to know is what is your sugar without, you have eaten any food in your body. All right, next one, the oral glucose tolerance tests. Oh, that's awful. The big thing about this test is patients, mainly those who are pregnant and we're testing for gestational diabetes, will have to come in. Usually they are NPO since, a couple of hours, 8 hours probably to be precise. They need to make sure to not carb up the night prior to, because that may actually adjust the test results as well and give a false positive. So they ate a well-balanced dinner, they come on in, they've been NPO, and they're going to have to drink about 75 grams of sugar. Guys, that is a ton. And it's usually this orange drink. It's probably 8 ounces worth or 6 ounces worth, and you have to chug it within like 10 minutes, and it's bad. It tastes pretty awful. Makes you want to vomit. And then you have to do it over again. Oh, nice. Okay. So you take this test, and they are going to draw your blood just before you drink this, and then 1 hour after this has been consumed, and then 2 hours after this has been consumed. Our goal is to see a sugar rise, but not rise too high. If it rises too high, then it's very telling that somebody is going to have diabetes. And once again, I'm going to give you the levels of blood sugar on the next slide. I'm just explaining the sugars test here. Okay, the next thing I want to explain to you is the, which one? Let's do the glycosylated hemoglobin A1C. This is where, I'm trying to think of an analogy. I'm going to skip the analogy. This is a test where we can actually see what the average blood sugar is over a period of 120 days. It is not altered by somebody's diet like the night before. They don't have to be NPO for it. You can have it tested any time of day, even if after they ate ice cream, because it is looking at a time span of 120 days. They typically do this test twice a year on diabetics. If they are meeting their outcomes, they'll keep it at twice a year. If they are not, and they want to monitor them a little bit more closely, they'll do it like 4 times a year and keep making medication adjustments, teaching the patient whatever they need to do. But yep, so that is called a glycosylated hemoglobin A1C. And I'll give you normals next slide. But no fasting for that one. Don't need to change, a special diet the night before, because it doesn't matter. Okay, let's look at the urine ketones that we can actually do for a patient. Do I actually even have that on there? I'm looking. I don't have it listed. Well, okay. I'm going to change direction and leave ketones off for just a second. Let me talk about the casual glucose, because I think I skipped that one. This is just a general screening. Maybe you've seen this done at like health fairs, but they will take a sample of your blood. Maybe you've eaten a little bit just before the test. Casual blood sugars are not as telling if a patient has prediabetes or diabetes, because it's not, let's just say there's a lot of variables, but it's a good tool, It's not recommended for diagnosis, but it does have a purpose at health fairs, because as you'll see on the next slide, if somebody is greater than X number, we can make a referral, because otherwise we don't need to do expensive testing at a health fair. Wouldn't work. The ongoing assessment, these are all of the different tests that are going to be done pretty consistently for our patients who are already diagnosed as diabetic. We will do the hemoglobin A1Cs. We are going to check their urine for microalbuminuria. I'm going to speak about that in a little bit. We're going to test their creatinine and their BUN, because diabetes is like, does not like the kidneys, or vice versa. Kidneys do not like diabetes, and it may show. That's why we're going to test for it a little bit later. Okay, let me move forward. Here are some numbers I really need you to memorize. Look at this schedule, commit it to memory. This is straight from your book. So our fasting blood sugars, remember how many hours you have to be in PO? Right, 8. Is it going to be altered if you have a high carb diet the night before? Yes, it will. So eat a regular meal, and hopefully whenever we take a patient's fasting blood sugar, it's less than 100. If it is within 100 to 126, we are going to have discussions with them, and we may retest them. We're going to coach them about diet. We kind of need to start intervening at that point where it's impaired or high risk. If on 2 occasions it's greater than 126, they get diagnosed with diabetes. Right. Our typical goal for our diabetics is to be anywhere from 70 to 100. That's considered the normal blood sugar level, 70 to 100. That GTT, that glucose tolerance test, the 2-hour one, which is more diagnostic than the 1-hour one. A normal blood sugar rise should roughly be less than 140. So you drink that 75 grams of sugar, awful. I should see your sugar come up, but no more than 140. If it's in the 140 to 200 range, we are possibly looking at pre-diabetes. If it is greater than 200, that is very diagnostic for you have diabetes. Hemoglobin A1C. I am always asking my doctor when she draws my yearly labs, okay, can we please check my hemoglobin A1C? Why? Because my dad is a diabetic. I want to do my best to monitor myself, and if I hopefully, do have an elevated blood sugar, I'm going to do whatever I can to get it right back down, because I do not want to get diagnosed with it. But if our patients have greater than 6.5% diabetes, greater than 6.5% hemoglobin A1C, they get diagnosed. If they're greater than 8%, they are very poorly controlled. Either they're newly diabetic and their sugar is completely out of whack, or let's just say they're diabetic and they've not been taking care of themselves very good. They'll tell you that their sugars are great. Sometimes they'll even make up numbers. I'm like, hey, let me see your log of your blood sugars, because they usually keep like a log, and they'll tell you stories. I tell you what, why don't you Google hemoglobin A1C of 13? Why don't you Google that, hemoglobin A1C of 13%, and look at the images, and you can actually see what a patient's average day-to-day sugar is. Is it 100? Is it 120? Hardly. Yep. Let's see. Our goal for a person who is a diabetic is to get their sugar roughly in the 7% range or less. That's our goal. Okay. Random or casual blood sugar. Remember when we do these? Usually at health fairs. If I test somebody's sugar, even if after they ate ice cream or something, it should be less than 200. And it's not very good to use as a diagnosis, but it should be less than 200. What was I going to say? Oh, and if it's greater 200 and they have signs or symptoms, then more than likely we're going to send them for further testing we usually use the fasting blood sugar test, the glucose tolerance test, or the hemoglobin A1C to test somebody for diabetes. Okay, here we go. I get asked this all the time, and you may be asking it too. What is the difference between type 1 and type 2 diabetes? What do you think? Yeah? Let's see if your answer is correct over here. For all diabetics, the main feature is high blood sugar. Now, it's the underlying problem which is really going to tell if you're a type 1 or a type 2 diabetic. It's either the lack of insulin or the insulin's action on cells is diminished. It's kind of like one or the other. So type 1 diabetics, they are usually younger age. However, any age can turn into a type 1 diabetic, but it usually happens less than 30 years old. We used to actually call type 1 diabetics child onset diabetes, but they don't use that term anymore. That's kind of outdated. On the pancreas, there is actual beta cell destruction, and they do not work anymore. They do believe there is an autoimmune attribute to this, so the body actually kills off the little islet cells that produce the insulin. It is an unknown cause, really, most oftentimes. Idiopathic, that's what that word means. Idiopathic. And type 1s can actually have their autoimmune system be triggered by viruses. They are starting to come out with studies such as like people have history of mumps or a Coxsackie virus, such as like hand, foot, and mouth disease, which is very common in kids. Oh goodness. But they have found that the body, in response to that virus, creates an autoimmune reaction, and it is triggered to turn the islet cells into non-functioning cells. Okay, type 1 diabetics are completely insulin dependent. Their body makes none. And the symptom onset, do you think it is abrupt, or do you think the onset is slow? The answer is abrupt. Symptom onset is abrupt for these patients. All right, on to type 2s. These are patients who have cells that don't respond very well to the body's own insulin. They're just numb to it. They've had enough of it. So we say that they are the insulin resistant type of diabetic. There is a little bit of a secretory deficit. Sometimes we find that our type 2 diabetics don't make as much insulin as a normal person, but they still will make insulin. You're going to find that 60 to 80% of your people who have type 2 diabetes are actually in the obese category, meaning their BMI is greater than 25. And of these patients, not so much the obese patients, but of the type 2 patients, some of them are actually going to require insulin, like injections. The pills are not going to be sufficient in trying to get their sugar under control. So what is the symptom onset for a type 2 diabetic? Actually none. There is really no acute phase for a type 2 diabetic. There's no drastic presentation onsets of symptoms. But they will sort of notice over time thirst, fatigue, blurred vision, maybe vascular problems such as poor blood circulation, and neural complications, maybe like stroke or TIAs. Let me go back to my type 1. These patients, their abrupt symptoms, I probably should have described them to you, but it's going to be the polyuria, the polydipsia, and the polyphagia, and we are going to see weight loss. A lot of our type 1 diabetics are very thin and skinny. Not all of them, but a lot of them. Okay, patients with diabetes, pre-diabetes or even metabolic syndrome will have changes to their systems, to their body symptoms, the macrovascular complications. So what we are looking at is coronary artery disease, or CAD, and we're also looking at peripheral vascular disease. I found a picture here of somebody with his legs. I know. Patients are also at risk for cerebrovascular disease, such as TIAs, those transient ischemic attacks, and hopefully not, but they can get strokes. And the immune system is actually going to be a little bit on the lower end and not as responsive to infections, and that's because of the high blood sugar. So one thing we need to do for our patients is do lipid profiles every year. We're going to try to maintain those blood pressures, in the 130 range if they're young, and maybe the 140, 150s if they're older, preferably 140s. Their LDLs, their low density lipoproteins, hopefully we're going to keep them less than 100. And if there's no cardiovascular symptoms such as poor blood flow, but if there are some, we actually are going to have their LDL levels less than 70 if they have symptoms present, like, bad circulation and stuff. We're going to focus on weight loss. We're going to focus on smoking prevention, and do make your patient report signs and symptoms of chest pain ASAP. When I say make them report, encourage them to get to a hospital quickly if they have that symptom. All right, let me go to the cerebrovascular disease part. They're going to have severe carotid stenosis, and to test for this, you can actually put the bell of your stethoscope on their carotids, and you're going to hear a bruit, a swishing sound. Now, I don't know if you know this, but stroke outcomes are actually worse if a person suffers a stroke and they happen to be a diabetic patient. It's actually going to be worse than in a non-diabetic patient. Their injury is going to be more extensive. For the immune system, as I mentioned, their white blood cell activity is down. It also inhibits gas exchange in the tissues, so this means the growth of microorganisms that lead to infection is promoted, and they can get real sick real quick. So we want to make sure to protect our diabetics from infection because their immune system is lower. So what else happens when somebody has diabetes? Just the stroke and a heart attack and maybe a low immune system? Well, a whole lot more actually. Here's where I feel that diabetes gets a little complicated. Okay, so one of the organs that's going to be affected are the eyes, and a patient can develop diabetic retinopathy. They say after 20 years of diabetes that nearly all patients have some degree of retinopathy. Now, with these changes, people can very slowly develop, vision loss, cataracts, and even open-angle glaucoma. What happens is the new vessels will actually begin to grow over the old ones because old ones become edematous and scarred, and that's where we will have vision issues. Now, do know before you test a diabetic, make sure their sugar is normal before an exam, because if in that moment a person has hypoglycemia, they're actually going to have blurred vision, but it's not because of the damage, it's because their sugar is low. So make sure their sugar is good before an exam, or you're going to get a false positive. Well, how often do they need to get eye exams? Answer is yearly. So please stress the annual screenings for your diabetic patient to look for diabetic retinopathy. And do know that people, as they age, normally have a little bit of vision loss, but if they have diabetes and as they're aging, it's going to be worse sooner. That's why we got to really preach that to them. Okay, the next microvascular complication I want to address is diabetic peripheral neuropathy. This is where damage has occurred to the sensory fibers to the limbs, and then we're going to have pain followed by loss of sensation. Diabetic peripheral neuropathy. Onset of this is typically slow. Both sides are going to be affected, and it's permanent. So once you get it, that's it. Now, there is such a thing as focal neuropathies. What is a focal neuropathy? Well, this is where a diabetic patient will have sudden, one-sided neuropathy. It is painful, but it is self-limiting and it goes away. Another nerve that gets damaged are the nerves that go to all of our organs. So let's look at the nerves that nervate our vessels. So if I move very quickly, if my nerves are damaged, my vessels are going to respond by vasoconstricting. Therefore, I'm going to be more prone to orthostatic hypotension. So diabetics are more prone to orthostatic hypotension. How about the heart? We actually have lots of cases of diabetic patients having painless myocardial infarctions. I know, that sounds scary. And how about the stomach? Yep, can you imagine a paralyzed stomach? Like, what happens there? Well, our patients are going to experience GERD. They're going to have sluggish bowels in general, so they're actually going to feel fuller quicker. They're going to complain of bloating, of nausea and vomiting. I feel like that one's a very common one, the nausea and vomiting. They're also going to complain of either diarrhea or constipation, so their bowel habits are not going to be normal in our diabetic patients. Well, how about the bladder? What happens to the bladder in a diabetic patient? Well, they are going to experience nerve damage as well to the bladder, so the bladder is not going to empty as well and as frequent. And what happens when you have urine that's maybe a little bit left in the bladder after you pee? Well, you're going to have infection, unfortunately. If a person has been diabetic for a long time, late symptoms include inability to even sense that their bladder is full, and they're going to have incontinence episodes. Another thing patients are going to have is nephropathy. That is kidney disease, basically. In fact, diabetes is the leading cause of the development of end-stage kidney disease. That is super scary, but have heart. They say that ACE inhibitors and ARBs offer protective effects for our diabetics to not develop kidney disease. Now, hypertension in kidneys is due to high sugar levels constantly. So if we have diabetes and hypertension, we are going to have loss of filtration follow very quickly. So that's a double doer. I do always recommend that our patients who are diabetic and may have a high BUN or abnormal creatinine, that they have yearly urine checks for microalbuminuria. They should have them at least every 5 years in a type 2 diabetic, and yearly for a type 1 diabetic. Okay, that will let us know if they're spilling protein in their urea, and that means that their kidneys are worsening, and we need to do some medication changes for that patient. Okay, sexual dysfunction, ED, is what's going to occur for our males. That's erectile dysfunction. They're going to have retrograde ejaculations. They're going to have fertility issues if their sugar is consistently abnormal. You can also have sexual dysfunction because of hypertension, smoking, obesity, but you just add diabetes on top of that and you're really going to have a hard time getting an erection. Let's not forget the females. So what happens to a female diabetic patient? In the sexual dysfunction category, they're going to have decreased vaginal lubrication, and that means painful intercourse. They also have decreased libido and sexual response. Just don't care. Okay, cognitive dysfunction. There is a higher risk for dementia. There is a higher risk for depression as well. So, who wants diabetes? No one? Okay. So you know all the bad that can happen now to a person who is diabetic. Let's try to help that person, why don't we? Because we don't want any of those things to happen. One of the things we're going to do is look at exercise and diet changes. I'm going to get to that in the next few slides, but first, medications. After we have tried diet and exercise, what meds are we going to start them? If they are a type 2 diabetic, we can actually begin with the pills. We are going to give them the lowest dose, and we're going to increase every 1 to 2 weeks until their sugars are good, or maybe the drug is maxed out. Some patients need 2 blood sugar medications, maybe even 3, to try to get their sugar under control. Do warn your patient that anytime they now buy over-the-counter medications, they need to consult with a pharmacist and make sure they are not getting ready to have a drug-drug interaction. Do know that some blood sugar medications decrease their effectiveness over time because a patient develops tolerance, so it's not unusual for a person to switch drugs after so many years. Let's talk about our first medication, metformin, also known as glucophage. Very popular. You can guarantee you are going to administer this medication. So I'm not going to focus so much on the action, but maybe the action of the medication. I'm going to focus on what you need to know about this. Metformin has the nasty side effect of bloating, diarrhea, and flatulence. We really want to encourage our patients, if they are on this medication, not to consume excessive amounts of alcohol, because this can cause lactic acidosis, which is, basically metabolic acidosis. This medication is good for diabetics who have good kidney function. However, after their kidney function begins over, say, a period of time, if a person develops diabetic nephropathy, we need to pull them off this medication. I know you don't know much about kidney disease, but let's just go with this. If somebody has got advanced or moderate end-stage kidney disease, make sure they are not on glucophage. Sometimes that gets overlooked and a patient just keeps taking it, and glucophage will begin to hurt already injured kidneys. All right, another thing we need to know about glucophage is that it has a dangerous drug-drug interaction with IV contrast, the ones that we need to use for, say, an MRI or a CT scan. So what do we do if a person's on this medication? Well, we're actually going to hold glucophage about 24 hours, and then we're going to do the scan, administer the contrast, and then we're going to wait 48 hours afterwards, and then we're going to begin the medication back. Well, what do we do with a person's blood sugar until then? Because it may spike up. I know. We'll probably give them sub-Q insulin and do really good diet control. Okay. Also, we want to hold glucophage, that same schedule, 24 before and 48 hours, not only contrast, but also anesthesia. So any of you who are going to be CRNAs one day, make sure to look out for this medication, glucophage, also known as metformin. And yes, person has to have adequate kidney function to be able to take this med. Okay, next drug I want to talk about is glipizide or glucotrol. Great medication. I feel like this is also very common. Patients need to take this with meals or just before it. We want to teach our patient the signs and symptoms of hypoglycemia. There are multiple interactions with this medication. Please make sure they do not consume alcohol, because they will have something called the disulfiram effect. The disulfiram effect. This means if you ever studied the drug antabuse, or disulfiram is the other name for it, if a person comes in contact with alcohol, they will violently vomit. Like, it's used for addicts who need to come off alcohol. But even though this medication is not for people who need to, who are battling alcohol abuse, it does have the disulfiram effect if they are on this pill and they begin to consume alcohol. So not a good choice if a person likes to drink. Okay, Actose. or pioglitazone. Now, we actually talked a little bit about this medication in the heart failure section, so I'm going to just mention this. There's a huge black box warning. This is a seriously no, do not give to anybody who has heart failure. Do not give Actos or pioglitazone if they have heart failure. They have to have a good heart. Another thing about this medication is we are going to monitor their liver enzymes. If we see a rise in the liver enzymes, we need to pull them off this drug. Okay? The next medication I have here is acarbose, also known as Precose. This is pretty cool in that it actually blocks carbohydrate absorption and its breakdown and absorption. So if a patient, say, skips a meal, please skip the pill. Okay? You only take this medication when you're sort of eating. So if they skip the meal, skip the pill. Got it? Next one down here is dulaglutide, also known in these new commercials called Trulicity. It's actually an injection. They call this an incretin mimetic, and it acts like natural gut hormones. Really neat in making the carbs and how does it work? You know what? Like I said, we're not going to worry about that, but it acts like natural gut hormones, and it's injected weekly, not daily. And we need to make sure that our patients report abdominal pain and nausea. This may mean that a person has pancreatitis. I actually have a video of a Trulicity commercial, and they mentioned that in their commercial. Okay, I know there's a lot. The next one we have here is Januvia or sitagliptin. These drugs are associated with rashes and allergic reactions, so after a patient starts it, please make sure to monitor for any kind of allergy. Okay. Canagliflozin, also known as Ivacana. I've actually seen a bunch of commercials for this one. This is incredible in that it lowers blood sugars by preventing the reabsorption of sugar and sodium. I know, right? They pee it out. So make sure to teach your patient these signs and symptoms of dehydration. Do assess your patient for hyponatremia, such as muscle weakness, inability to concentrate, abdominal cramping, and tachycardia. It does predispose patients to UTI and females to yeast infections, so they need to know to report that. Okay, let's talk about glucose monitoring. I feel like I've preached your ears off about these pills and other injectables. All right, how many times do they need to check their sugar? They need to check it about 8 times a day, maybe even more, especially if they have an irregular eating pattern or there's a change in their exercise. We want to teach them the signs and symptoms of hyper or hypoglycemia and what hypoglycemic awareness is. It's very crazy, but some patients will have their sugar dropping and they won't even think about it. Maybe because they're busy or they just attribute their shakiness to something else. They need to check their sugar more frequently during times of illness. You need to check their sugar before or after exercise. Maybe if a patient has a really bad case of gastroparesis because of the autonomic nerve damage, then you're going to check it more frequently. And if there's any adjustment of their anti-diabetic medications. Ooh, yes. And if they are on steroids, right, like corticosteroids, maybe even check your sugar more frequently for preconception planning. Maybe you're trying to get pregnant. Patients need to check their sugar more often. All right, let's talk about injections. Woo, that's a lot, I know. I want to introduce to you the insulin pen. If we're using a pen, right here, as you see on the left-hand side, we must remember to prime the needle. I have a video of how to use and operate a, it's not called inject, it's actually called a flex pen. I have a video, please watch, of a person, it's actually an animation of how to use one. You need to know that you dispose of the needle cartridge in the sharps box, not in the trash. And actually, can you use, say, one of these pens in between patients? Like if my new admit is scheduled for Levemir, but their meds are not up from the pharmacy, and hey, your patient has a Levemir pen in their drug box, can I actually use it for my patient? The answer is no. Okay, well then how about if I clean it in between patients? Still no. What if I can't find the disposable needles that you see, the little needle cartridges on top? Can I stick the injection port at the needle attachment point, maybe with like a little insulin needle, and pull up what I need out of it with an insulin syringe? Answer is no again. I know. Are the needle cartridges single use or multi-use? What do you think? One-time use only. Do not reuse those little needles. Most of them have a safety guard, so you can't use it twice, but some do not. All right, let's talk about the insulin pump. Cool, huh? This can actually be very effective at controlling blood sugar. There's more flexibility if a meal is skipped, because then you can just, skip the dose right there. On the next slide, you'll find out if we put mealtime insulin in here, or do I put basal insulin? What's neat about these is some of them are actually waterproof. Some may not be. You actually have to get little products on, say, Amazon or something if they're not the waterproof type, but some are. Issues with insulin pumps are infections at the site. So that means we need to switch sites every 2 to 3 days. They just pull that little sticker off and they put it somewhere else. Patients also have a higher chance of ketoacidosis. That is from accidental cessation, maybe obstruction, like maybe the tube kinks or something, and even mechanical pump failure. The pump removal, if this accidentally happens, definitely leads to hyperglycemia, and as you know, that leads to ketoacidosis. Oh my God, please know your patients. If they happen to be, say, changed to NPO for surgery, and you know that they have one of these, do take it off, because if not, they are not eating and it is still pumping a little bit of insulin in them. Yeah, just don't say, okay, my diabetic patient's a PO and be good with it. No, cool. They need that off if they're NPO. All right, or maybe you can start a drip of dextrose 5%. Doesn't matter, one or the other. All right, knowledge check. This is from slide 2 about syringes and your choice, and your choices between them. This is actually the ones that are going to be used in the hospital that we're going to do clinicals at. So which one will you grab if you need to give insulin? Orange top, very good. So how do you do it? You're going to pinch the skin and give it at 90 degrees. Where are you going to give it? Any sub-Q location. Please look at your book if you need a refresher of where these locations are. But you're going to give it 90 degrees for most patients, and you're going to insert the whole needle. Unless they are skinny and frail, then do 45 degrees and insert the whole needle. You're going to inject about 2 inches from the navel. They say absorption is fastest in the abdomen. Please make sure to rotate within the region. So if you went on the left abdomen, go to the right abdomen and keep going back and forth to prevent day-to-day variability in absorption. Because they do say the arm absorbs differently than the leg, than the stomach. They all are different. Please avoid going in the same spot. And this is to help prevent lipoatrophy. This is where the tissue is actually going to get scarred. And sometimes this becomes the patient's favorite spot because they are not able to feel the injection pinch as much. However, it has a slower absorption rate. So do rotate sites within the same region to prevent lipoatrophy. Okay, let me show you something else. Morning hyperglycemia. Morning hyperglycemia. How does this happen? Well, listen up, because NCLEX loves to quiz students on this phenomenon. This is called the dawn phenomenon, morning hyperglycemia. Well, there's actually two reasons. Let me back it up. There's two reasons for morning hyperglycemia. One is the dawn phenomenon, and the other one is the Somogyi effect, or the Somogyi phenomenon. Okay, let's talk about the dawn phenomenon. So at night, your body will release adrenal hormones, which will spike the sugar and sort of tell you to wake up. This occurs from about 5 to 6 a.m. We can manage a patient's morning hyperglycemia by giving them insulin overnight. In fact, maybe normally we give NPH insulin at 5 p.m. with their dinner. Instead, if we notice they have morning hyperglycemia, we'll give it at like 10, just before they go to sleep. Now, the other type of hyperglycemia, AM hyperglycemia, is called the Somogyi phenomenon. This is where the body has a counter-regulatory response from nighttime hypoglycemia. They eat well, or to fix this, they have to eat a well-balanced snack at night, and then they're actually going to track the sugar levels and exercise near bedtime to see if any of those are contributing to their nighttime hypoglycemia, which the body tries to adjust itself and it turns to morning hyperglycemia. Well, how am I supposed to know which one a patient has, so I can treat it appropriately? Well, the answer is you are going to tell your patient to check their sugar just before bedtime, and then again at 2 to 3 a.m., and then upon awakening. So let's do a situation. If I said my blood sugar was 120 at bedtime, a little abnormal, and then at 3 a.m. it was 80, and then I woke up again, in the morning, and it was 200. Do you think I had the dawn phenomenon or the Somogyi effect? Answer is the dawn phenomenon. Why? Well, my sugar didn't dip low before, below normal, didn't go below 70. So I then had the dawn phenomenon. Well, what are we going to do for that patient? We're going to change up their insulin, and we're going to make it later. Right. Give it at like 10 something. Okay, now other situation, just to keep you thinking. What if I have a blood sugar of 89 at night, then at 3 a.m. it's 65, and then in the morning it's 150. I now have experienced the Somogyi phenomenon, and for that patient with that issue, you're going to give them an evening snack. So in the middle of the night, their blood sugar doesn't tank and their body respond. A carb and a protein, please. Let's talk about meters. This is, oh man, there's so many different types of meters. They have some with like large numbers. There's some that talk back to you if you are visually impaired. Do make sure when you're using these to use the teach back method, and teach your patient to do the proper storage of the strips. If they are exposed to air, they can actually lead to inaccurate results. So open the little cartridge up, pull a strip out, and close it promptly. When you're doing this in the hospital, please make sure to wear gloves and to clean the instrument, the glucometer, before and after each use, because they say that hepatitis B can live dried up, like in a little dried up blood spot, for 1 week. And also there are single-use lancets that you do not use one on each patient, it's just one and done. This is a picture of a continuous glucose monitoring system. Do know that there is a lag time between the capillary and the interstitial blood sugar of about 30 minutes. So it is meant to supplement, not totally replace checking it with your finger, like a finger stick. You're going to change the patch every 3 to 7 days. I love this idea though, because it can actually send a report and alert somebody, if like a family member, if their sugar is way high or way low. A student of mine, she was a type 1 diabetic, and she actually had one, and sometimes she didn't even know that she was going hypoglycemic because of that hypoglycemic unawareness problem, and her mom would call her and say, hey, your sugar's in the 60s, go eat something. So I found that was fascinating. Non-insulin diabetics are actually using these as well because they feel that they can track their sugars better, and we can actually see their regimen if it's working or not. All right, let's talk about insulin therapy. Whew, I know, this is a lot. This is a high alert drug. The first one you are looking at is Novolog, or insulin aspart. What's important to know about insulins is not only that you have to inject them just before a meal, but you want to know the onset time, like when I give this shot, how quick is it going to start working? You want to know the peak time, because we want to warn our patients not to have the heaviest exercise during the peak time, and we want to know the duration, so how long is this drug going to last in somebody's system. So what is the onset time for insulin aspart? It is 15 minutes. And we usually are going to give this medication maybe about 10 minutes before their meal is in front of them. That's when it's going to start working. That's when they need to start eating, is within 10 minutes of administration. But onset is 15 minutes. The peak is 1 to 3 hours. And the duration is 3 to 5 hours. And FYI, these are also in your book. 15, 1 to 3, duration 3 to 5. And yes, you're going to have to remember these for the test. All nurses know these. All right, the next one I want to discuss is regular insulin. We actually call the Novolog rapid acting, and we call regular insulin short acting insulin. You can also call it Humulin R or Novolin R. The onset for this is 0.5 hours or 30 minutes. It peaks in 2 to 4 hours, and the duration is 5 to 7. Now take a look at these vials. If I'm out of, say, the vial on the left, can I substitute in the one on the right? Please pause the video so you can really think and tell me an answer. Yes, no, or why? Or and why? What do you think? Answer is, can you substitute the right for the left? H-E-double-L, no. Please read the vial concentration very carefully. Why do we even have the one on the right that is 500 units per ml rather than the 100 units per ml? Well, you know, some patients, if they are very, very insulin resistant, or maybe the patient's morbidly obese, we would actually need to give them a higher concentration of insulin, like if they're 700 pounds or something, rather than like 3 shots of the 100 units per ml. We can do the stronger dose. But yes, please make sure your unit, the one that you're supposed to give, is the right concentration. They are not the same. No. Okay, the next insulin that we are going to administer our patient is NPH insulin, or Humulin N. The onset for this is 1.5 hours. The peak is 4 to 12. And the duration is 16 to 24 hours actually. We give NPH insulin twice a day. This is the one, only one, that is cloudy and must be agitated well before administration. You have to roll it in between your hands, kind of like inverted a bunch too. Did you get that time? 1.5 hour onset, 4 to 12 hour peak, and 16 to 24 hour duration. And I'm going to tell you something about the peak too. I promise. I promise it's important. All right, here's our other insulin. Insulin glargine. This is also known as Lantus. The onset for this one is 2 to 4 hours. It has no peak, and it lasts 24 hours. Right, no peak. I want you to now look at the bolded statement on the package and vial label. Read it out loud to yourself. What does it say? Do not mix meds, other medications in the syringe. Right. You are going to give this one straight. This is not one that you mix. Patients take this straight. All right, you're going to store it in room temperature. All of them you're going to store in room temperature, and you're going to keep it from light. Oh, I see. Okay, the Lantus is typically stored in the refrigerator. All the other ones are room temperature, and you're going to discard it after 28 days, all of them. Do refresh your memory on the process of pulling up and mixing insulins, the short-acting or rapid-acting with the intermediate one. Don't ever forget, clear before cloudy is how you draw them up. You are also going to be guaranteed a timing question. I know there are tons of insulin types for you to remember. I mean, remember, we are trying to replicate the normal insulin release pattern from the pancreas. I mean, that's really hard to do. The pancreas does a basal release of insulin, which is, to support the balance of glucose production and use between meals. We call that the basal insulin. Which basal insulins do you think were introduced to you today? Did you say Detamir, insulin Gargine, and NPH? Right. And then we also want to provide our patient additional insulin for meals or mealtime insulin. We know these insulin types as the prandial insulin. Which one of the ones I just introduced to you do you think are prandial insulins or mealtime insulins? Exactly. The insulin aspart, which is rapid acting, and then the short acting one, which is called regular insulin. Good. Another thing I want to tell you about the peak times and why all nurses have this committed to memory is because if I administer a patient insulin, I want to go back and round on them when the insulin is at its strongest or during that peak time. That is not a time to say reprioritize your day. You go in and you check that patient during the peak hours of your administration of when that medicine was administered. Yeah, that's better. I know all of that was a little overwhelming, so what I'm going to do is end this part of the diabetes lecture, and I'm going to call this part 1, but please do make sure that you open up the next one and watch part 2. Bye-bye. May the odds forever be in your favor.